Okay. All right. Thanks, everyone. We're going to go ahead and get started. Thanks for tuning into this week's installment of the National Fellow Online Lecture Series by AMSSM. I'm Robbie Bowers. I'm one of the co-chairs of the Online Education Committee that helps put on to these lectures every week. And thanks, everyone, for joining. A few housekeeping things like we do at the beginning of all of these lectures. Our next lecture will be next week on pelvic health and athletes, and that'll be at the same time on Wednesday night. Shafali Christopher will be the speaker, and Julie Creech-Organ will serve as the moderator. So tonight we have a great honor of having Dr. Eric Wagner back speaking on thoracic outlet syndrome. We did a similar talk back in November of 2020 on the same topic and had a really good response to it. And I think it'll be good from a continuity standpoint to just do an update about 3.5 years later on the same topic and go into some of the things we've learned in that time. Before we get started, a few housekeeping items. Again, like we say every week, this is to serve as an adjunct to your individual fellowship programs, educational content. We want to provide fellows with direct access and educational experiences to a variety and diverse group of AMSSN members, and like tonight, invited guest speakers. And then also this is to help in CAQ exam preparation, apart from some special topics that we discuss from time to time. Turn off your camera, mute your microphone if you can. If you have any questions during the course of the talk, please put those in the chat function. I'll ask those questions to Dr. Wagner at the end of his talk, and we'll have a discussion regarding those questions. And then if you can, please complete the evaluation at the end of the lecture. We have added this on to our intro slides. We are seeking input on this lecture series. We'd love suggestions and recommendations about different topics and speakers. You can find the suggestion form on the AMSSM website if you go to the Education tab and then the Fellow Online Lecture Series. And then also you can use this QR code to get to that suggestion page as well. So again, tonight we have Dr. Eric Wagner speaking on thoracic outlet syndrome. It's a great pleasure to have him. He's a great colleague of mine here at Emory in Atlanta, Georgia. So Eric did his undergraduate work at the University of California, Davis. He lettered 3 years in basketball, then went on to complete medical school at the University of Chicago. He completed his orthopedic surgery residency at Mayo Clinic and then did 2 fellowships, first hand and microvascular surgery at Mayo Clinic, and second, he was selected for the prestigious Harvard's International Shoulder and Elbow Fellowship at Mass General and Brigham and Women's Hospital in Boston, Massachusetts. Since he's finished fellowship, he's been at Emory, and he is an extremely well accomplished researcher and speaker and holds many leadership positions in the world of orthopedics and orthopedic surgery. So with that said, Dr. Wagner, I'll give you the floor and let you take it away. Thanks for being here.
Awesome. Thank you very much. It is my honor and privilege to join this again. As Dr. Bauer said, it was about a year ago that we did this and love the response. And hopefully there'll be a similar sort of way of approaching this. Thoracic outlet syndrome is one of these things that we are in the process of learning a lot about. It's something that, both when Robbie and I were first sort of getting into this and learning more about it, especially with regards to a large percentage of our patients being kind of young athletes, trying to understand it a little bit better and understand why there were shortcomings in some of the current treatments and the difficulties in diagnosis, as many of these patients had been kind of bumped around a lot. So this lecture is sort of somewhat of an update. I've changed it to view more currently how we are approaching things, what we've learned, show a series from a surgical standpoint of some of the success that we've had, and then from a diagnostic and non-surgical standpoint of an algorithmic approach that we've sort of started to develop, and we're in the process of publishing on. And so hopefully there'll be more and more to come in years to come. So disclosures are not relevant to this presentation and don't have any impact on what we're going to be talking about. But I should disclose that I am a product of my mentors, both in the United States and abroad. And a lot of these gentlemen have had a huge impact on kind of some of the stuff we're going to talk about and how I've helped to shape some of this TOS type of stuff. So today I'm going to talk about really radiating shoulder pain. And oftentimes associated with scapular dyskinesia. And thoracic outlet or neurogenic thoracic outlet is going to be the sort of framework that we're building it around. However, I'm going to also talk about some of the other syndromes that either are associated with or potentially can mimic a TOS or a radiating shoulder pain type of problem. And hopefully this will give you a sense. If you look at these DDR images, this is actually my shoulder on the right, and then there's a patient with scapular dyskinesia on the right. And you can see how little scapular motion there is. Lots of glenohumeral motion, very little scapular motion, and how limited that patient is. You can imagine the difficulties this patient's going to have. This is actually a young athlete that we saw in our clinic that has this problem. All right, so here's a case example, 20-year-old female, one of the original ones that Dr. Bowers and I sort of treated. Collegiate softball player, and came in with pretty significant pain limitations and had to sit out her sophomore year of softball. So she had this radiating pain. When you think about radiating pain and some scapular dyskinesia, there's a lot of different things you can think about. These are some of the ones I'm going to talk about. So thoracic outlet syndrome or neurogenic thoracic outlet syndrome or Petrous minor syndrome, kind of all on the same spectrum, at least from our perspective. There's the idea of scapular dyskinesia or scapular-thoracic abnormal motion, so STAM. This is where the scapula doesn't move properly and potentially contributes in some respect to either the shoulder or the nerve problems. Scapular winging is a more severe form of STAM, and this can be from paralysis. Often people that come in with scapular winging actually have had prior surgeries or interventions for shoulder instability, as they often are associated with that. And then you have suprascapular neuropathy and quadrilateral space syndrome. And a lot of these I'm going to sort of touch on and hopefully sort of enlighten a bit. But first off, though, as I don't think I have to convince many people in this audience, but why is the shoulder the most fascinating joint in the body? Well, there's so many aspects of the shoulder, at least in my mind. I mean, let alone you look at what athletes do with their shoulders. It's truly remarkable, the degrees of freedom, the what they're able to do, the force that they're able to do it with, and how it stays stable, how it stays motion, and then you can imagine then some things that are sort of off. You can imagine what happens when this happens. So look at this massive rotator cuff tear. You can see how a patient's head kind of elevates and hits the acromion, and you can actually see here the greater tuberosity kind of impacting against the acromion in this DDR image. So the shoulder is fascinating. It's also fascinating that it works so well, but it's also makes sense when it stops working, why that has such an impact on the patients. One of the other points I sort of want to bring up is so many of us, so many providers that treat shoulder pathology focus solely on the glenohumeral joint, when oftentimes a lot of the problems potentially actually come from the scapulothoracic joint, and we don't appreciate that and sort of treat the glenohumeral pathology, but the sort of foundation of the shoulder and the a lot of what you're treating in the glenohumeral joint actually is caused by some abnormalities in the scapulothoracic, and that's kind of relevant to this topic, and you'll see many examples throughout this talk. And once again, kind of showing that you can imagine the impingement, you can imagine the rotator cuff problems, you can imagine the limitations in motion and the pain that this patient on the right is developing as a result of the lack of scapular motion. All right, so I'm here to talk about thoracic outlet syndrome. That is going to be the main focus of this. However, as Robbie Bowers can tell you, many of these patients that we see either have thoracic outlet syndrome plus something else because the scapula is not moving properly and it's creating some of these issues, or potentially some of these patients that we're referred to as actually don't have TOS and actually have some of these other problems. And so I'm going to kind of go through the gamut of these things, starting with thoracic outlet, moving on to some of the other scapular related pathologies, and then kind of talk about our approach and maybe some cases that might help illustrate our approach. So, all right, so TOS, traditionally, this has been a problem that has been treated by vascular surgeons and to a lesser extent thoracic surgeons. It's thought of as something that from a vascular standpoint, where you have the thoracic outlet, so it's coming out of the rib cage. As you can kind of see in this illustration, you have a compression of the first rib against the clavicle for the vein or the artery. Makes a lot of sense. When this happens, often you get this sort of Raynaud's type phenomenon. Occasionally, you'll even get some lower trunk symptoms in the hand. What I should note, even on this simple drawing, is you can imagine this upper trunk symptoms, the shoulder symptoms, really from the first rib standpoint, it doesn't make sense why that would be driving this. And instead, from a vascular standpoint, when you have these lower trunk symptoms, there's Raynaud type symptoms, it makes more sense as a vascular phenomenon, not a neurogenic phenomenon. As these patients with the vascular thoracic often have this claudication in their hands, maybe it can be confused as Raynaud's. Sometimes on angiogram, as you can see in this case, you'll actually see very significant narrowing of the artery. And then the classic one is this Addison test. So extended the affected site, inhale deeply, potentially you have a reduced pulse. You can also elevate the arm above the head, see if you have a reduced radial pulse. So neurogenic thoracic outlet, this is more of, at least in our mind, and what we're going to be referring to it as something that's caused by the nerves being irritated. And often this is sort of an upper middle trunk, shoulder tightness, shoulder radiating pain, kind of gets worse with shoulder extension. Sometimes you'll see some scapular dyskinesia. Often it's a history of repetitive overuse. So pitchers, softball players, volleyball players, swimmers, a lot of these athletes are the large percentage of patients that we're seeing with this. It's been super surprising, and I think Robbie can talk about this. Since we've sort of started paying attention, how many patients actually have this pathology that we probably have been ignoring or not paying attention to in the past? So I think it's a lot more common than we think. I think in the general, a lot of these patients sort of get ignored and sort of get told, oh, your shoulder's fine, there's not much to do, or they have surgery that's maybe not indicated and don't totally get better from it. So from our standpoint, it seems like the tenderness of palpation, Tinel's, the medial, the coracoid is a big thing. Sometimes you can look at the interscalene triangle as well, the suprascapular stretch tests. A lot of these traditional, so Adson, Roos, and Wright, the literature's born that these aren't so specific or sensitive, and although they're helpful to do, aren't necessarily what's I would say you should rely on when making this diagnosis. So this kind of shows. So you do the Tinel's at the interscalene triangle, Tinel's at the actual pectoralis minor, tenderness palpation, the pectoralis minor. Bring the arm back in extension. This is the stretch test, suprascapular stretch. So kind of stretching the arm away, bringing the arm back in protraction, seeing if there's pain there. You can look for some scapular dyskinesia. Sometimes it's subtle, like in this case. Sometimes it's more prominent, but it's where the scapula kind of adjusts on its way up and way down. And then you can do things like measuring some of these indices. So pectoralis minor length is one of the things, or the index. So you measure the length from the coracoid to the fourth rib when they're just standing at rest. Oftentimes you'll see this length can be up to like 2 or 3 centimeters shorter on one side versus the other when they're retracted. And then you can calculate the pectoralis minor index. You can also look at scapular protraction height, medial-scapular angle, medial-scapular height. All these are sort of signs for this protraction in the scapula, for the scapula being brought forward, and the pectoralis minor and some of the other anterior structures being quite tight. So our diagnosis is both a diagnosis of exclusion and a diagnosis of inclusion. When I say exclusion, I mean we get a brachial plexus MRI to make sure that there's no plexus lesions that we can see. We get an angiogram to make sure, with the arms up and the arms down, to try to diagnose to see if there's any signs of compression of the artery or the vein, or if there's any blood clots or anything else that could be explaining a vascular TOS picture. We do an EMG, not only necessarily to look at the inclusion of TOS, but more to make sure there's not like cervical radiculopathy, maybe something else like a compression neuropathy more distally. Sometimes, yeah, in the EMG, we've actually seen that the suprascapular nerve can have some signal, not necessarily paralyzed, but some signal. And then we'll do that diagnostic injections. I do think ultrasound is the mainstay for this. So Dr. Bowers has some beautiful ultrasounds demonstrating compression underneath the pectoralis minor. You can do injections where you basically block the pectoralis minor. You can also block the scalenes as well. or you can do injections to numb up the suprascapular nerve to see if that helps, especially if the patients have a little bit more radiating posterior shoulder pain. So this kind of shows some ultrasound where you can do the injections. You basically are going to block sort of the pectoralis minor, and you can imagine as it runs sort of underneath, what you're doing is you're freeing up some of the space if it's no longer contracted down, freeing up hopefully some of the space for these nerves and vessels to run. These are pictures provided by Dr. Bowers, kind of showing both the pectoralis minor and some of the question underneath it, especially when you bring the arm into extension and how you can kind of see some of the compression below it. And once again, kind of arm at side versus arm extension, you can see some of this compression of the structures below the pectoralis minor as you bring that arm into extension. That kind of simulates a lot of the patient's pain. So this is sort of our current way of thinking about this. So if you have a Tinel's or a tendinous palpation medial to the pectoralis minor, on the medial aspect of the core bone, positive stretch chest, have some aspect of scapular dyskinesia, although that's not really required, and then have a positive response to injections. I think that's really important. I think that's not talked about as much in a lot of the studies. We've talked about a bit in some of the stuff we published, but in some of the stuff that's coming out, we're going to talk about a lot more. But I do think the positive response to the injections is a very important aspect of it. And this can be lidocaine, where you block it, or, Robbie often will do, in certain patients, in certain situations, will even do Botox to temporarily paralyze these muscles. And then you have to have a negative vascular and EMG workup. So I do like to do that. I do think it's really important, especially in these young athletes, if you're going to expose them to some sort of surgery or prolonged sort of or try Botox or whatever it is you're trying to retrain their shoulders and their scapular girdle. I think it's really important to make sure it's not actually something that you want to intervene on. So I have please reach out to me if y'all are interested. I have a whole PowerPoint of all of these exercises. So there's different scapular exercises, different stretching exercises, different ways that you can sort of help to open up the front part of your chest, or patients can help to open up the front part of your chest, retrain the scapula, retrain scapulohumeral rhythm. These are some examples. There's other ones that I think are quite helpful. I think, but feel free to send me. We have protocols, both non-op and operative protocols of this. And I do think figure eight braces are kind of a mainstay. This is actually a patient of mine who I used to try TLSO braces to kind of help open the chest. And she came to me and she's like, hey, this is a much more effective brace. This is what we used to treat clavicle fractures in. And she's like, you should put patients in this. It works really well. And since then, she's right. It's a very effective way to kind of help to remind them to open up the front part of their chest, to retrain their shoulders to be kind of back in a more protracted posture and not compressed on the neurovascular structures on the front part of their chest. All right. So TOS. Not everything that has scapular dyskinesia or winging is TOS. And that's sort of the next section of this talk, is talk about some of the other things that either can be combined with it or instead of it. And this is this idea of what's called scapulo-thoracic abnormal motion, or STAM. So Bassam Elsan actually came up with this terminology, and I do think it's a really appropriate way of kind of making scapular dyskinesia better understood. Because this can happen from the pectoralis minor being too tight, can happen from dysregulation of even the rhomboids or the levator scapulae or the serratus not functioning properly. But it also can be a product of paralysis, like serratus or thoracic or trapezius paralysis. So there's a lot of different definitions of this. It can also just be a product of functional abnormal motion. I mean, the patients themselves actually just move it in a abnormal pattern. This is often seen in some of the hypermobility disorders like EDS and Marfan syndrome. All right, so these are some, sorry, the videos aren't playing, but these are some examples of some of these. So you have serratus anterior paralysis, where you lose the connection of the scapula to the body. You have pectoralis minor, where you have this dyskinesia, but it's not, it's still kind of rotating. And then you have the trapezius paralysis, where you kind of like, it droops translates laterally a bit. And these are all sort of obviously scapular abnormal motions, but they're quite different pathologies. So the trapezius's main function is sort of to elevate and participate in scapular external rotation, meaning it rotates the scapula sort of in an external rotation manner to allow for abduction. When it's not there, you sort of lose both the height of the trapezius, the height of the shoulder, but you also lose that scapular external rotation, and then kind of it translates laterally from the body. The rhomboids really primarily function to retract. And so if these are abnormal, either you retract and internally rotate, and it gets sort of this abnormal posture, or if it's not working properly, you'll see this kind of translation laterally and limitations from a loss of connection to the midline. The serratus anterior, this is one of the more common ones you see that's either dysfunctioning or paralyzed, especially in athletes, if you have an impact in the side. And this is sort of this classic winging, loss of connection to the body, loss of basically kind of like looks like an unstable scapula. And these are Bossum and Moore showed this nice study looking at the shoulder flexion resistance test. I like to use the scapular stabilization test as well as a way to kind of help to diagnose this. Show you this as an example in the future. But this kind of shows a quick assessment of what I was just talking about. So you want to look at this is a swimmer, a collegiate swimmer. You want to look at how the scapula is moving. So this is on the good shoulder. You can see he's able to resist. So serratus anterior is working in this side. And I kind of feeling the edge. This is the looking at the serratus anterior, and you can see how much it wings out and how it's clearly not moving in this case. The push-up test is not the best test. I would actually use this kind of pushing the shoulder against resistance in a more effective way than the push-up. See some of the limitations. Been able to compensate really well with some of the limitations the patient has. And then so this is the stabilization test. So stabilizing the scapula against the chest wall. And you can see how this is able to correct it, basically get almost all the way up, especially when he's a relatively large male, and so it's hard for me to totally stabilize scapula. Once I'm able to really stabilize scapula, you see how well it corrects it. And I think, at least in my mind, that's like one of the more effective ways to truly diagnose serratus anterior paralysis. We use the DDR X-rays. You can see the value of the DDR X-rays. So this is their AP view. Not much that you can see there, but you can see on this DDR view how very little scapular rotation is going on. And these are two other patients where you can see very little axial scapular motion. So really good glenohumeral motion, but very little axial scapular motion. And you can imagine how they're limited by that very little scapular motion that's going on. So when you have thoracic abnormal motion, often these people have this like pain in their scapula. Maybe it's radiating posteriorly. Sometimes it's radiating anteriorly, or they have rotator cuff symptoms as a result of their lack of scapular motion. They'll have some dyskinesia, as you can kind of see in this exam. Botox is really helpful to help diagnose the pectoralis minor's role, maybe even the rhomboids. And then obviously an EMG to look at the serratus or the trapezius, make sure those are actually firing and functioning properly. And then as with anything, depending on what you're treating, but vast majority of things you want to start with therapy. And then consider something like a pectoralis minor release or surgical intervention if you think it's a pectoralis minor driven syndrome. Only after you've failed pretty extensive therapy, pretty extensive attempts at retraining the scapula. So one kind of thing that I think Bowers and I have noticed more and more is some of these patients with posterior radiating shoulder pain or deep shoulder pain have, in addition to either scapular dyskinesia or alone, had this sort of suprascapular neuropathy. And this is because this is a mixed motor sensory nerve. It innervates, although the motor goes to the supraspinatus and the infraspinatus, the sensory part actually innervates the superior part of the capsule, the posterior part of the capsule, and some of the posterior skin. And so you do have some significant pain if you have suprascapular neuropathy, particularly posteriorly. And in some cases, you can correct the scapular dyskinesia, you can make this go away. In other cases, you can actually have to intervene. Laurent Tibalt-Lafosca taught us about this. We arthroscopically can expose the ligament and arthroscopically release the ligament to help release the nerve. Quadrilateral space syndrome. This is sort of another one that can be kind of associated with, in some respects, scapular abnormal motion or TOS. Can also be a product of it. It can also be different than it. And sometimes we've had people sent to us that have this kind of posterior pain, posterior axillary fold, so like the posterior part of your armpit. They have pain right there. It gets worse with resist external rotation. Often these are pitchers or overhead athletes. Sometimes we see it in rock climbers. And it's compression of the nerve here as it runs, this axillary nerve as it runs with the posterior humeral circumflex vessels. And as it comes through the teres minor, the teres major, and the triceps. And so therefore, resistant external rotation is one of the ways to sort of to help diagnosis, but also you can try injections right into this quadrilateral space using the ultrasound guidance, and that's been an effective way from with Bowers to help us to decide if that's actually their pathology or if it's something else, because these are often kind of vague symptoms and patients have trouble really localizing this until you really push on that posterior axillary fold and then until you kind of do the resisted external rotation. So once again, pain, location, posterior axillary fold, so posterior aspect of the armpit. You get pain in the posterior armpit, this would be one of the things you're thinking about. There's not much else there. Maybe a latissimus muscle tendinous tear. There's not much else there. Posterior radiating pain, especially kind of radiating from the posterior aspect around the shoulder. This is pretty specific for this. And then, for me, at least, abduction versus external rotation is kind of the mainstay to help diagnose this. And this kind of shows, abduction, poking right at that posterior axillary fold, and abduction resisted external rotation. They have pain associated with that. Sometimes on an MRI, you'll actually see a cyst that's sitting in the quadrilateral space, and this helps to make that diagnosis as well. EMG often will show some abnormalities in the axillary nerve, and that also will often it's not a paralysis, but maybe just some subtle abnormalities. And so quadrilateral space syndrome, this is something that we do start out with sort of both rotator cuff and scapular combined protocol, retraining the scapula, but also working on the rotator cuff. And I think diagnostic therapy injections are helpful. Surgery is not often needed, but occasionally, especially in some of these really high impact athletes, you have to. And once again, the most of the therapy I do think is the scapular therapy is a really important aspect of this. All right, so next sort of type of scapular pathology I want to talk about that's kind of in addition to the TOS and scapular thoracic abnormal motion is scapular winging, and this is traditionally thought of as either serratus or trapezius. Serratus thought of from a long thoracic nerve palsy and trapezius from a spinal accessory. This can be either a paralysis, can be Parsons-Turner syndrome, or direct impact from a game, from a collision, maybe even a car accident. This is something that's is unfortunately the serratus anterior we do see a fair amount of. Trapezius paralysis is relatively uncommon, fortunately. And you can treat these with things like the pectoralis major transfer if it's truly paralyzed. So you're taking the pectoralis major or half of the pectoralis major and transferring it to recreate the scapula, or what's called a triple transfer in the case of a trapezius paralysis, where you instead of the trapezius, take the levator scapulae and the two rhomboids and kind of reconstruct the upper part of the trapezius, upper middle part of the trapezius. This goes to one example, a cheerleader, and you saw her images earlier. Fell during cheerleading, immediate pain, diagnosed actually with shoulder instability, was indicated for surgery. But you'll see clearly that was not the sort of most appropriate treatment. And so you can see clearly there's something abnormal in the scapula. You see how it sticks out. You get how limited she is with regards to motion standpoint. Yes, she has pain with abduction, but it's not because of apprehension. It's not because she has anterior shoulder instability. It's because she has clearly a disconnect of the scapula from the chest wall. You can see the sort of superior air subluxation. You can see the protraction, the internal rotation of the scapula. And this was not a hypermobile person. This is somebody who had a paralytic shoulder. You can see here why they thought maybe posterior instability. So you can see the heads pointed at backwards. Maybe um, this is mistaken for posterior instability because it almost looks like a patient that is posterior unstable, but this patient's posteriorly feels posterior unstable because they have no motion in their scapula. Brachioposterior MRI was basically negative. Reasonable sort of raised muscle belly. But the EMG did show some abnormalities in this race that clearly was not recovering. And so the sort of decision was that given we're a year and a half out, given it's been going on for a while, failed such extensive scapular and shoulder retraining therapy, we ultimately did do the surgery. I'll just show quickly. This is not meant to show too much technique, but basically we take this pectoralis major. So through an incision on the front side, isolating the clavicular head, you can take the sternal head, transfer it all the way, the sternal head, the pectoralis major, all the way along the rib cage, connect it to the inferior angle of the scapula. So this kind of helps to, you can see the serratus anterior, or at least what the serratus anterior was. You can imagine what it looks like now, or how the sternal head almost looks like a serratus anterior. And then you reconnect the clavicular head of the pectoralis major back to the arm. So this is kind of what it ultimately looks like. So they still have a pectoralis major, but the sternal head is now connected to the inferior angle of the scapula and recreates this. We've sort of published on this, showing pretty good outcomes. And this shows with this patient, you can see very, very good outcome. Definitely did not need a posterior shoulder procedure. And you can see how we were really able to reestablish or scapular motion, reestablish our overall shoulder function with this. And this is another gentleman. You can see pre-operatively, the DDR X-ray is very limited scapular external rotation, and post-operatively, you can see almost a normal shoulder, really good scapular external rotation, reestablishing that sort of connection to the body. All right. So now kind of getting to this approach for TOS. So we talked about a lot of the different potential, either differential diagnosis or concomitant pathologies. But when we talk about this pectoralis minor driven, maybe there's some aspect of the subclavius, maybe there's some aspect of the scapula, but having the pectoralis minor drive at least a certain aspect of these patients that have thoracic outlet syndrome. Kind of wanted to show you from an anatomic standpoint why this kind of makes sense. So if you look at the thoracic outlet, the true thoracic outlet is actually where the vessels come out of the thoracic cavity, go into the arm, and cross the first rib. And it makes sense why these would be compressed with the first rib's elevation to the clavicle. And to be clear, the main role of the scalenes is actually not to compress the nerves. It's actually to bring the first rib up to the clavicle. And so when you think about scalenes being involved, it's really traditionally they bring the first rib up to the clavicle and cause this compression of the vessels. When you look at the nerves, it doesn't really make as much sense why the nerves would be compressed by the first rib. They cross the first rib very, very far from the actual clavicle itself. On both the inlet and outlet views, it really shows how far the nerves are from the actual first rib and the clavicle, and how it doesn't really make a lot of sense why that neurogenic thoracic outlet would be driven by a first rib compression to the clavicle. And instead, in a lot of respects, we kind of think about it as a pectoralis minor driven kind of scapular girdle problem, where when the pectoralis minor is really tight, when the scapula is not moving properly, you can imagine why these nerves would be irritated. You can imagine why they'd have issues, especially when they extend the arm, especially when they do overhead throws or other overhead problems. And just in our practice, it seems like about 5% of the cases that we get referred to that we diagnose with TOS tend to be about vascular TOS, true vascular TOS. And then neurogenic TOS really it seems to be more often what we're seeing. The pectoralis minor driven, occasionally scalenectomy scalenes can be involved. We've kind of gone away from scalenectomy for the most part, with the exception of certain cases. But I do think the pectoralis minor seems to be a big contributing factor in a lot of patients, especially these athletes that we see. All right, so case presentation, going back to that softball player, unable to play, radiating shoulder pain. You've seen the exam. Positive sinus palpation, defect minor. Petrous minor length 13 versus 15 on the other side. Index was 7.7 versus 9.0 on the opposite side. EMG did show some supraspinatus neuropathy, got really good relief with the pectoralis minor block as well as the supraspinatus nerve block. And a la my colleagues, I've modified this a bit since they've sort of published on it, but I kind of want to show the illustrations. I'll show you a brief video showing what we see in surgery for this. So given the responses, we did decide to do surgery. These are some of the portals. So it's arthroscopic surgery. You basically use a viewing portal here. You have this arthroscopic cautery that you can release the pectoralis minor off of its insertion onto the coracoid, as you can see here. So you can see the pectoralis minor on here. You can see the pain is located where you do that diagnostic block. You release it off, and you kind of open up kind of the nerves and vessels are traveling below it. I do like to go ahead and open the and release the subclavius. I don't know if that's totally necessary. But this shows. So this is the arthroscopic surgery that we do. These are some of the incisions. And often in true TOS, I will release the suprascapular nerve if they have any signs of scapular dyskinesia. So that's the arthroscopic suprascapular nerve release. You can see the nerve really clearly. You can see how safe this is. That's one of the beauties of this approach is you can see things so clearly and you can see it very safely. I'm coming back along the coracoid, and then you'll see here. I'm now going to come on the opposite side, and pretty soon you're going to see some of the anatomy. And I think that's why I'm showing this. I realize this is not a surgical video, but I want to kind of show you some anatomy. So there's your pectoralis minor. This is your conjoint tendon. This is your coracoid. This is your pectoralis minor again. And there's your CA ligament. So this is kind of like a T it forms. And then when you're thinking about this from a diagnostic injection standpoint, or you're ultrasounding this is the pectoralis minor that's here. Here's your coracoid, here's your conjoint. And this is what you're releasing. You're releasing this pectoralis minor, you're focused on this pectoralis minor. You can see after release it, how much it retracted back. You can see the brachial plexus running right below it. So this is your lateral cord right below the pectoralis minor. You can see how tight this pectoralis minor is. So watch you see how it snaps back. So this is a very pathologic problem. There's your actual nerve. You can imagine how that potentially would be involved. And you can follow this brachial plexus all the way up to under the subclavius. And actually, you can even connect the dots, and you'll see in a second, where after releasing the subclavius, I can connect the dots from where I did the suprascapular nerve release to where the plexus meets. And you get this whole, there's that probe that I left previously in front of the suprascapular nerve, and there's your suprascapular nerve. You can see how you can kind of like imagine this whole area is going to be tight and contracted down, and why these nerves would be irritated and why these nerves would have sort of issues. And this is the actually artery that you can see, and it's beating, but you can imagine why this would be a sort of a problem. And you can imagine why patients potentially would have issues with this. So this softball player went back to softball, did quite well. We've now treated many athletes. We even have eventually going to have a series coming out of some of the athletes that we treated with this. This is a really cool case. I like to show, I think I showed it previously on the talk, but I really like to show this because this just shows the power of misdiagnosis. This guy's been misdiagnosed for about 10 years, had been chronic methadone use, and had some prior shoulder surgery, as you can see, from some of the arthroscopic incisions. But he had significant pain, scapular dyskinesia, problems, kind of all the way throughout. And once again, chronic methadone use, been kicked out of many pain clinics. And you can even see his anger tattooed on his back. I mean, this is a really bad problem. And this guy really didn't have much solution. Robbie blocked him, got really good relief from the block. So went in and did the pectoralis minor release. And he did quite well, was off methadone. You can even see at 2 weeks the response he had. And he's actually lost weight since. He looks phenomenal. One of the patients I'm really proud of and really happy with kind of the response. And this at least hopefully opens your mind to, or opens your eyes to some of the things that I think we've discovered. This sort of, or actually before I go to this, one of the things hopefully you'll be inspired from this is there's a lot of things that you will kind of learn and hear about. And some things are awesome and we have really good answers for, and we have really good solutions for. And there's some things that we don't have great solutions for. And as you kind of are going through training, I know this is targeting residents and fellows. As you go through training, I would encourage you, take in what you can, realize everything you're learning is from people who are very experienced and masters of what they do. But also, don't be afraid to question. Don't be afraid to keep your eyes open. Don't be afraid to think outside the box. I mean, this is how innovation happens. And I guarantee 15 years, 20 years from now, the stuff we're doing now is going to be a bit outdated. And there's going to be lots of new cool stuff that we're doing and treating a lot of these different pathologies. So this gives you a sense of kind of our exposure. I do think that the vascular literature has done a wonderful job of teaching us about thoracic outlet syndrome, but I do not think it's total. I don't think we totally understand what TOS is, what this whole range of scapular pathologies are, and the impacts of them. And this kind of gives you a sense. I mean, when you do a first rib resection, not only are the outcomes good in some respects, but variable in others, but there are major complications associated with these first rib resections. So in this recent systematic review published about a year ago, it showed that you had major complications in 5 to 40%. And these are significant complications: brachial plexus injuries, subclavian artery and vein injuries, infections, pneumothoraces, really, really serious stuff. So our experience from an arthroscopic approach. Now, I don't think every patient is indicated for this. And I'm not saying that every patient with TOS should have this, but I do think in the patients that are indicated, it's very safe. We've had one frozen shoulder in a volleyball player. I do not know how that happened. We did not go inside the joint, so no idea how she got a frozen shoulder, but she did. And I've had one superficial infection in a portal site that does happen, but once again, no real what I would consider major infections. I mean, major complications. And we have had about a 12% failure rate with this. I think we're still, Bowers is a wonderful partner, and he and I are still trying to figure out how to best indicate these patients, what's the best algorithm for these patients, whatnot. This is something I think we're learning a lot. We're in the process of publishing on, and I think hopefully, we have a pretty rich experience at this point of seeing, 100 plus, probably even over 200 at this point, referrals for TOS, and we are in the process of trying to figure out some of the ways to best treat these patients. But nonetheless, there does seem to be a spectrum of neurogenic TOS. There's some association with some scapular problems. Probably there also still the problems with kind of a mixed picture when you have the scalings and the first rib. I bet there's a component of kind of neurogenic and vascular TOS in some of those patients. But others have this problem in the cervical girdle. Maybe it's the pectoralis minor. Maybe it's some of the other structures that are causing this kind of decreased space available on the front part of their chest. And remember all the other syndromes we talked about and other potential things that can be associated with this kind of radiating shoulder pain type of picture. I do think surgery or Botox into the pectoralis minor is a very reasonable option, very safe in the right patient that sort of fits that criteria. At least in our mind, once again, it's the response to the injection is probably the most important. Lidocaine plus or minus Botox. Botox can also help them with therapy. So I do think if they can get approved, that's a really helpful adjunct to treating this. And Bowers can talk a little bit more about his experience with that. Tendinous or tennis palpation medial to the pectoralis minor, pain when you stretch the arm back in extension, or you bring the arm back in protraction, the scapula back in protraction, some sort of scapular abnormal motion or scapular dyskinesia. Ideally, you have a diagnosis of exclusion, so negative vascular, negative EMG workup, negative brachial plexus workup. Make sure this is not something that's mimicking something else. So make sure you are not dealing with vascular TOS, not dealing with some sort of nerve injury. Maybe, interesting enough, when we were looking up the outcomes of our surgeries, a large percentage of those patients, that 12% that didn't work, I think 6 or 7% of them ended up having cervical radiculopathy and a cervical spine intervention that ultimately helped with their pain. So we misdiagnosed them, or maybe we didn't misdiagnose them, but we their main problem wasn't necessarily the scapula, even though maybe they had some scapular problems. Maybe that was being caused by the cervical spine pathology that they had. So I want to thank you for your time. Thank you for this opportunity. Please, I want to encourage residents, fellows on this. Think outside the box. As you're going into your own career, think about how. I think innovation is sort of the beauty of what we do. Think about ways that you can better treat athletes. If you think about it, in general, when we are treating young people, athletes that are either competitive or recreational or just people trying to get back to certain activities, we have really good at ways to get people back, but it is not perfect. And I think there's a lot of cool research going on in biologics. There's a lot of cool research going on, better understanding with imaging. Ultrasound is really taken over. I think there's a lot of cool things going on. I encourage you to sort of stay up to date on a lot of this stuff and really push the envelope. I mean, there's lots of fun stuff. This is one of the areas that we've been sort of trying to push the envelope a bit, or at least trying to better understand. And hopefully there'll be lots more that y'all will see throughout your sort of career. So thank you. Reach out to me. This is my email. This is my cell. Happy to interact with any of you that are interested in this topic. It's an area both Bowers and I really enjoy. So please reach out to us if y'all have questions.
Thanks, Eric. Really appreciate it. Great talk. And so I'll make a few comments before. So if participants can put any questions, if you have any in the chat function, I'll make a few comments before we get to questions on kind of my side of things that you had touched on. That one patient that you had mentioned that was on chronic methadone, I think that was early on in our kind of journey with this pathology. And that is the one patient that I can look to that really opened my eyes to this, like, wow, this is really powerful. And I think he'd been misdiagnosed for so long and how so many different things go on. And so that was one of the initial patients that I know just opened my eyes to it. And since then, it's been really fascinating to see, with our diagnostic algorithm and treatment algorithm, how much different I think that is from what you may read in a textbook or hear when you hear a discussion about thoracic outlet syndrome. Is when you typically hear about it, it comes from the vascular surgery world, and it's all about patient comes into the office, they have a certain story that sounds like maybe they have thoracic outlet. You do a couple physical exam findings. There isn't a lot done with diagnostic injections, and if you've already done some therapy, then the suggestion is let's do a first rib resection. And we've seen a number of these patients that have come into our clinic that have had a first rib resection offered to them. They didn't feel comfortable with it, came to us. And when we go through the diagnostic algorithm, we find out, hey, this is more, there's a scapula and pec minor component to this that is more, that's causing it. And then do great with arthroscopic pec minor release. And also on my side of things, we've actually have a lot of success now, and for the most part can get Botox covered. I mean, 90% of the time we're getting Botox covered, maybe more than that. And we have patients that, like you said, if we can loosen up these structures and allow them to progress through therapy more effectively, that can be definitive management as well. And so we do have some non-surgical treatments that can be effective for this. And so I want everyone that's on this call or viewing this video later on to understand that this is such a dynamic process. It's not as straightforward as, oh, it's just your scalenes in your first rib and you need a rib resection. There's a dynamic process with the pec minor and the scapula that can cause a variety of ways that these people can present. And so, like Dr. Wagner said, just kind of question what you hear about thoracic outlet, because I feel really strongly the way that we're working these up is the right way to do it, because I feel like it allows us to pinpoint the pathology. And that's not to say that some of these patients have scalene and first rib-driven neurogenic thoracic outlet. We have a number of patients that they respond really well to a scalene block and don't respond at all to a pec block. And we work with a very well-qualified vascular surgeon here at Emory that we send people to that does first rib resection, and those patients can do great too. But I think we have to be a little bit more nuanced in our thought process and how we go about these and how we work them up. So that's kind of my 2 cents on the topic. Now, and then I'll just say real quick, I won't belabor it. There's actually one of our fellows is going to present this at the AMSSM conference. Is going to present this data with one of the Rising with Research talks. So, be real quick. I think it's actually the last day on Wednesday for people that are sticking around to talk about our thoracic outlet syndrome diagnostic block data. And so, if you look in the last just 12 months, we did October to October, and aren't huge numbers, but specifically, if we look at an athletic population, specifically overhead athletes, we had 27 overhead athletes that we treated in the last year, and 13 of these athletes had both pectoralis minor and anterior scalene blocks. And in overhead athletes, 11 of the 13 found that the pectoralis minor was much more helpful than the scalene block. Only one of the athletes found that the scalene block was more helpful. Then there was another one in there that kind of had a little 50-50 response. But I think that's just some objective data that points to the fact that, we're not just saying this, especially in overhead athletes, the pectoralis minor contribution to neurogenic thoracic outlet symptoms, it seems to be the primary driver, and the diagnostic block data that we have tells us that and speaks to that. So I'll quit waxing poetic about this. So we do have some questions, and I'll weigh in if I feel like I need to as well. So the first question, it says, for diagnostic injection of the pec minor, what is your injection approach, and how do you determine what if the injection was effective? And so I guess I'll take that one. So the injection approach is you find and we have an ultrasound course at the AMSSM conference coming up too on Saturday morning on ultrasound of the overhead athlete, and my section is on pectoralis minor, and so I'll demonstrate how you find pectoralis minor and the approach to that. If you're interested in stopping by for that course, I believe it's at 6:45 or 7 a.m. on Saturday morning for those that want to get up that early. So we isolate the pectoralis minor. You first find the coracoid. You swing your probe down, come in our oblique fashion down into the chest here. So your probe ends up being oriented like that. And you just have to make sure your needle clears the coracoid, and we go down into the pectoralis minor. And there's been cadaver studies that have shown that the primary nerve innervation to the pectoralis minor is in the middle third of the muscle. So I try to get it as close to the middle third of the muscle as I can to get the block. And then we also, and we can talk about this further as well, we also feel like this is not just a muscle problem. It's also, there's nerve irritation associated with it as well. So we'll inject some of the medication into the subpectoralis minor space to get around the nerve structures to create a little bit of nerve block to try to calm some of the nerve symptoms as well. So you get about 60% muscle block with that, and we get a little bit of a nerve block that can help with diagnostic relief as well. And how do we determine if it's effective? We rely on the patients to tell us. And so these thoracic outlet symptoms are variable, and no one patient or no two patients are exactly the same. And so I tell patients all the time, and they frequently get to us and they've seen multiple different doctors along the way. And I say, you understand your symptoms and know your symptoms the most. We're going to do this injection. I want you to go home immediately after this and do things that normally would exacerbate your symptoms. And then within that period of time, they'll know if it's effective, and they'll send us a message the next day and say, yes, it definitely helped, and my symptoms were 80% better. We asked them to put a percentage on it. And we'll do that for a pec minor, and we'll stage, if we want to do scalenes too, we'll stage those injections. And so you'll hear a lot about diagnostic injections where people are diagnosed with TOS where they have pec minor and scalenes at the same time, which I think is a huge misstep, because you can't delineate from there. If you're just going to go, full speed ahead and just say your only surgical approach is first rib resection, and you're going to take out a rib and release the pec at the same time, that's fine. But I think you're going to miss a lot of patients that are primarily driven by the pec minor and don't have much of a scalene component as well. So that is, go
to
ahead.
add to that, Bowers, one of the things Bowers does and we do is we kind of try to get patients to give us a percentage relief. So they go and do whatever pain they have, and then they try to give us a certain percentage of what like percent relief it is. And I do think that's important. And that's something I think that's going to be part of our understanding as we go forward, is what percentage relief is necessary and how much, like how much does it have to go away to actually be effective for us to primarily target it and treat it. But yeah, it is when I present on this in some of the other settings, there's people are very passionately, for some reason, very passionately against using blocks as the primary way of making decisions. And it makes just zero sense to me because these physical exam maneuvers are so, I don't know, so arbitrary and so non-specific. So yeah, it's really powerful. Blocks are really powerful in helping this diagnostic algorithm. But
Yeah, I got a so we're doing a Delphi study currently. We just started with it with Dr. Wagner and myself to try to figure out how people are diagnosing TOS, and we sent it out to a number of different docs and different specialties, and I got a phone call from one of the vascular surgeons who was you know did did not agree, to say the least, did not agree with the way that we go about doing things, and did not think that diagnostic injections helped at all. And I asked him why, and some of his responses felt like were a little archaic, and to just say that all you need is history and physical exam for these. I think again that's a bit of a misstep, especially given if you look up. So if you go online and look up YouTube, if you go to physio tutors and type in some of these thoracic outlet physical exam maneuvers, they say in every one of those videos they tell you the literature that supports these physical examination tests, and for almost every one of the thoracic outlet ones, it is very poor quality, or they can't say one way or the other given the amount of data. So they're very hit or miss, and so to just rely on the physical exam maneuvers, I think, is a bit of a misstep. So next question's from Dayton Schneider. He's one of our PMR residents here at Emory, and he's asking for you, Eric. Do you ever find
yeah,
useful EMG, or including rhomboids in the EMG useful, and also for the 12% failure rate that were
yeah. So
right?
yeah. So the rhomboids, for the first question, the rhomboids, I do think EMG, when we do these EMGs, we get rhomboids, we get supraspinatus nerve, we get serratus, we get trapezius, everything around the shoulder blade, because I do want to know, is there any underactivity or is there anything abnormal with any of those muscles? Because I think a lot of this, once again, is a scapular problem. So yes, 100% rhomboids is a helpful, and rhomboids can actually be overactive instead of pectoralis minor and cause like a kind of retraction type picture. It's more of an internal rotation of the scapula, but it's slightly different picture, but it can be sometimes mistaken for this protraction you see with the pec minor. And then the 12% failure rate, at least what I showed in that series, this when I define failure, I mean that there's a surgical grading criteria of did they actually improve or not, and failure means that they didn't improve to a certain level that's we consider successful. And yes, those patients were usually a little bit older, and the ones that had radiculopathy, had obviously some underlying C-spine problems. So that was a bit of a compounder. What I showed you, that 85 patients, not obviously not all of those are overhead athletes. That's another series Bowers and I are going to put out. But that the first series we're putting out is just dealing with all kind of TOS put together, not just focusing on the overhead athletes.
Yeah. So the next question is there utility in trialing a diagnostic pec minor block before doing an EMG or imaging such as CTA in order to save time and resources if neurogenic TOS is most likely based on history and physical and diagnostic block?
Yeah, yeah. So, I mean, you can speak that too, Bowers. I think it depends. In certain athletes, we will skip some of this. Some of the times they'll already come with that, but we'll skip sometimes if it's very specific and it looks like, hey, this is like classic pain here, protracted, gets worse when you extend it back. And then you get the block and they get perfect relief. I still like those people to try therapy. So while the time savings I think is less, if you really are pushed for time, maybe it's a season or something like that, maybe you're trying to get back to it at a certain level, then yes, it is worth just doing the pec minor block and not doing the EMG and the CTA. I still like the angiogram and the EMG as a way, especially in athletes, young athletes, just to make sure this is not something else that you're missing. But we have done that in sort of special circumstances. I don't know. What are your thoughts, Bart?
Right. Yeah. I think that will require a special circumstance because, um, like you said, it helps us to rule out other pathology, and so you just don't want to go into full speed ahead on TOS if
Yeah.
something else is going to show up on their EMG or on their imaging studies that there's a compressive lesion or something like that. And so it helps you to rule out and be more firm in your diagnosis. So, people can still get a positive response to a PEC block, yet have something else that's causing their symptoms beyond just the PEC minor. One lady that I think about is we had a lady maybe a few years ago that she had a big ganglion cyst kind of sitting underneath her plexus, pushing up on it back behind the PEC minor. And so she responded well to a PEC block, but then, maybe you could see the cyst a little bit on ultrasound, but couldn't really get down deep enough. And then you got the advanced imaging with MRI, the brachial plexus, and saw this big cyst pushing on it. So, that's not going to be the most common finding, obviously, but those things are out there. And so I think still having the EMG and the imaging can be helpful just to make sure you're not going to miss something.
100%, especially in athletes.
Yeah. And then I'll take this next one. Eli asked, is there any literature supporting hydrodissection as a conservative treatment option? And really there isn't any good data out there as far as ultrasound guided brachial plexus hydrodissection as a treatment option that we can rely heavily upon. I think you may hear some anecdotal stuff out there, but we don't have enough data to support it for me to even make an educated comment on it, because there's just no data out there. And I know some people are doing it, but we need to start tracking outcomes if we're going to do those sorts of things. And my primary means to treat conservatively from an injection standpoint is the Botox injections right now, just based on outcomes that we have in our clinic, and then also what we see in the literature.
And Bowers, if I could add to that, so hydrodissection in a static process, maybe like supratrabecular neuropathy, but carpal and cubital thinks it makes a little bit more sense. But we are talking about a dynamic process, and so in my mind, in this case, this scenario, although maybe it would give some temporary relief, I think Botoxing the pectoralis minor makes a lot more sense. And especially if you Botox it, then you get them to work with therapy and retrain their shoulder blades, maybe where their figure eights, that type of stuff. That's you're correcting a dynamic process. And so in my mind, targeting the muscle makes a lot more sense than targeting just the nerves. So
yeah, I totally agree with that. That's a great point. And then the last question we have in the chat, Jared's asking, can you review the basics of scalenectomy? For example, which scaling, full resection versus partial? What's the rationale for it?
Yeah, so scalenectomy is scale. The scalenes, as you know, the brachial plexus comes out through the scalenes, and then the scalenes also are attached to the first rib. The original thinking behind the scalenes was that they contributed to bringing the first rib up to the clavicle, thus contribute to the process of this compression of the vessels coming out of the thoracic outlet and being compressed against the clavicle. And so scalenectomy, either in combination with first rib resection or scalenectomy even by itself, the thought is to potentially correct that dynamic process that's going on. And then usually you're targeting the anterior scalene. Sometimes it can be anterior and middle, depending. And there's studies that sort of have shown both. And when you think about the compression, the compression is, some people think maybe in addition to the first rib, there's also the scalenes that can kind of hypertrophy and push on those nerves. I'm not sure if that's totally been borne out. I think that's something we're still learning about, I guess. And that would be sort of between the anterior middle scalenes, both potentially being involved. There is a systematic review comparing first rib resection to scalenectomy, and showing not a big difference between the scalenectomy is a little bit safer than a first rib resection. I think the overall success rates are probably a little bit higher with the first rib resection. So there's not huge differences with that treatment. But most people, if they feel like it's a scaling first rib problem, they're going to do the first rib resection plus a scalenectomy, and that's kind of our approach. And that's what the vascular surgeons that we work with, that's how they kind of approach it.
Right, exactly. If you look at the kind of conservative literature as far as diagnostic blocks, a lot of them you'll read about, they'll include just the anterior scalene, but based on the insertion of the anterior and middle scalene on the first rib, when I block them, I do both the anterior and the middle scalene every time. It just makes more sense to me. Although you'll see in the literature sometimes, or a lot of times, just the anterior scalene being addressed. But I typically will do both of them just on kind of my own understanding of the anatomy and the pathologic process. So. And then, lastly, just to follow up from Jared, after resection of the scalenes, are there any functional deficits that you've noted? I guess
so
the same thing with pec minor for the
yeah.
pec minor too.
So there's some things in the body that just are not needed. Appendix being one of them, obviously, but long head of biceps is another one that's probably not totally needed. So the pectoralis minor, I would actually argue, is the least needed muscle in the body. I think it causes problems. I don't think there's any functional ramifications from it. It's not that I don't think. We have 25 plus year ladder J studies showing that these high level athletes get ladder J's and have no functional ramifications, not having a pectoralis minor attached to their coracoid anymore. So I can say from the pectoralis minor standpoint, there is no functional ramifications releasing it or paralyzing it. From a scaling standpoint, it seems like there's no functional ramifications either. That being said, there is you maybe worry a little bit about some scarring around the plexus depending on where you're releasing it and how you're releasing it. But no, there does not appear to be any functional ramifications from not having scalenes. It doesn't really the function of scalenes. I don't know if it totally outside of maybe helping with breathing. I don't know if it totally makes sense why you'd have like significant functional ramifications. So, but that's not really been borne out.
Right. And whenever I Botox these muscles, which a lot of times, based on diagnostic injection response, we come back and do Botox, I'll do pec and scalenes at the same time if they get a lot of relief with pec. But then, even if they get a little relief from scalenes, I'll still Botox them. And I have not had a single patient that I've Botox these muscles complain of any sort of functional deficits at all. So when we're fully paralyzing the muscles, they don't have functional deficits. So kind of our Botox data speaks to that as well. Okay, so that was the last question. I think, given the fact we're over an hour already, we'll wrap it up from there. Thanks again, Eric, for giving this talk. I think it was super helpful and a good update from our discussion that we had back in 2020. So for those interested, you can go on the AMSSM YouTube page and look at the original talk from November of 2020 and compare it to the update from now. And so again, please feel free to reach out to myself or Dr. Wagner if you have questions about this pathology or our process of how we work it up. And I know both of us will be happy to talk to you about it. So thanks again, Eric, for giving the talk tonight, and see everyone next week.
Thank you for this opportunity.